The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. There are two things that I really like about the episodes for this month. One is we're talking to Jeremy Kendrick again, and it's always delightful to talk to Jeremy Kendrick. And the other thing is that he was kind enough to indulge me. So what we're going to talk about this month is going to be kind of a grab bag of things that I feel like I need to get smarter about because of various things. I have felt sort of a gap in my practice, and he is kind enough that he's indulging me. I'm hoping that these are as important to you as they are to me. Welcome back, Jeremy.
Hey, thanks, Paul. I appreciate the invitation. Nothing gets me excited like the concept of a psychiatric grab bag. So happy to be here.
Yeah, it's the gift that everyone hopes for is a psychiatric grab bag.
It's the gift that keeps on giving.
So first of all, I would say you need no introduction, but you are, a great child psychiatrist in this area and have been so instrumental in the call-up program. Do you want to just say something about the call-up program and also tell us about any disclosures that you should make?
You bet. I appreciate the opportunity. Yeah, I've been a child and adolescent psychiatrist here in Utah for more years than I want to admit at this point. But one of my passion projects, along with some of my colleagues, has been this idea of getting expanded access to psychiatric subspecialty care to the areas where most of the psychiatric care is happening, which is primary care and our pediatric colleagues. And so one of the areas that I've worked in because of the passion, I'm a board certified pediatrician in addition to being a child and adolescent psychiatrist. So this is an area that I've really felt passionate about. And so one of the things that I was very excited about was that the state of Utah very generously understood the need for this and has funded for a number of years now a primary care access line that any primary care provider in the state can call Monday through Friday, 9 a.m. to 5 p.m. and be connected with a specialist child psychiatrist to discuss anything that's coming up, a patient with maybe a tricky diagnosis, or maybe you're stumped on medication options and want to talk through it. And so the call-up program exists specifically for that purpose. And basically you can visit, if you Google call up in Utah, you'll see the website there, but it's part of the Huntsman Mental Health Institute. But the easiest way is just to give us a call. And the phone number there is 801-587-3636. And yeah, we're available on weekdays throughout the day and love talking with our colleagues in primary care on the state. That said, to that end, that's about as far as I have to disclose. I wish I had my secret project making me billions, but at this point, not a whole lot to disclose.
And as a user of the call-up program, let me just tell you that whatever billions you're not making from it, I tell you, it is a real lifesaver, quite literally sometimes. So let's dive in. So this week, I want to talk a little about the concept of risk assessment and what it takes to make sure that kids are leaving the office safe. And the thing that's a little distressing for me sometimes is I feel like I get information, but I don't get enough information to really satisfy myself that I'm sending someone home safe. So why is this so hard?
Well, it is hard to think of something that's higher stakes than kind of life or death of the patients we're caring for. And when you take that concept of being the person that's trying to make that judgment and trying to do that between your 4-month well child visit and your, otitis media visit, it becomes, I think, a cognitive burden that I think is really difficult for busy primary care providers to wrap their minds around. And I guess one of the most important things that I would say through this is, the goal of risk assessment isn't to predict the future. We just can't do that. The goal really is to just reduce the risk that is in front of you today and build a safer next, 72 hours. And I think that is the major goal of risk assessment. And if you approach it in that way and take the stakes away from like you are making like a determination that will determine life or death, I mean, you are making a determination that's going to keep your patient safe. And I think there are some good structured ways to go about it that make this less of an intense and less of an intimidating experience. But it is incredibly hard, and it's a major cognitive and emotional burden in the practices we work in.
And one of the really tough things is that these may be thoughts that a patient has shared with almost no one. I had a patient not long ago who her mother said, something is going on. I want to leave you two alone to talk about it. When I asked her about it, she said, I can't talk about it, but I can text you about it. And
Mm.
so she had me bring my phone into the exam room and use a means of communication that she was more comfortable with. And she told me that she had plans and means to harm herself, and she ended up in the hospital that night. But I worry that there are some of these conversations. I mean, this happened because of a very astute parent knew that something was up. And I don't think this is somebody who would have talked to me otherwise.
Yeah, I'm impressed by the ability of pediatricians to adapt to the needs of their patients. And I think that's a great example. I think the ability to facilitate communication is really the first step to being able to have these conversations. And I will agree with you that a lot of times the pediatricians, the primary care providers, the doctors, may be the first ones to be hearing about this because it is very difficult for kids to talk to their parents about these things sometimes. There can be all sorts of dynamics that exist in that relationship that make it difficult for the child to talk. Yet, the place where you go to talk about things that are maybe have to do with your well-being and your health is the doctor's office. And I think it's a privilege we have as healthcare providers to kind of have that built-in trust. But along with that, comes the opportunity to hear some pretty weighty things from our patients at times, for sure.
Let me ask you a question. One of the things that I worry about is I worry about when I ask a patient about it, if they're a suggestible person, am I opening Pandora's box?
Yeah, no, that's a great question. And I think that's a common thought that a lot of people have. Will I plant the seed of this thought in somebody who would not have had it otherwise? And what I will tell you is this is something that has been looked at very, very closely through a lot of different mechanisms in the literature. And, I think it's pretty reassuring that most of the studies and the reviews out there really show that asking about suicide absolutely does not increase suicidal ideation or behavior.
So we
That
shouldn't be afraid.
we should not be afraid. And, asking doesn't kind of plant the idea, but it does allow for an opportunity to uncover that idea if it exists. And for many of our patients, especially those patients who you're just talking about that may have not told their parents about it, unless we ask, they're probably not going to offer it up. And so it really is in the asking that we open the door of opportunity and allowance for patients to trust us with this really intense topic.
So what things really predict risk? What's the difference between, say, active or passive ideation?
Yeah, no, and that's where things get so tricky because when you talk about risk, I mean, first of all, there is no best predictor for suicide risk. I think we have tried in vain through research efforts for, multiple decades to understand what are the single risk factors. And we really know at this point that there is no single risk factor, but it really is this multifactorial combination of baseline psychiatric health, understanding where a patient operates from at their baseline, pairing that with acute stressors that may or may not be present in their life, pairing that with the capability that they have or access to means, like you had just mentioned, and then also placing all of that within the context of protective factors, things that may dissuade a patient from engaging in these thoughts. And so risk tools, screening instruments that, they're necessary, but they're not sufficient. We can't predict this. But what we can do is assess these individual categories and understand them. That first category, psychiatric symptoms, that's something that we have a pretty good idea with our patients. We've been seeing them for a while. We know what their baseline burden of mental health issues might be. Acute stressors, that's another thing that we as pediatricians do a pretty good job talking to patients about. What's going on? What's going on with school? What's going on with, was there a breakup? Being able to assess that. The capacity and access issue, that really is part of this discussion about safety and risk. And at the point that we start talking about the potential presence of these thoughts, it's a very natural extension to ask about details of what those thoughts look like. And those details include things like access and the means that the patient has been considering. And I think you really have to put all of those factors together to come up with a bit of a overall feeling of what the risk actually ends up being with a patient. Now, one of the major kind of categorizations that you mentioned that I think is a really helpful construct is this idea of passive versus active suicidal ideation. And so passive suicidal ideation really to me is a representation of the suffering the patient has. So if a patient talks about just suffering to the point that they just don't want to be alive, that really is this idea of passive suicidal ideation, this idea of like, I just do not want to be alive. Now, at the point that those thoughts transition away from, I don't want to be alive, but I'm not necessarily thinking about a specific way in which that might happen, to I don't want to be alive to the point that I don't want to wait around for something to happen. I want to actively engage in some type of behavior that will hasten that outcome. That's when you shift it into this idea of active suicidal ideation. And so I'll often use the example with patients. I have some patients who will describe to me that, they're suffering, they're struggling, and they have the thought that they would never do anything to end their lives. But, holy smokes, if an accident occurred or if they were in a car accident and passed away, they would welcome that. That's a great, and usually patients resonate with one of these descriptions. So that's kind of more the passive. And then the active is, that same kind of starting place. I'm suffering, I'm struggling, I don't want to be alive anymore. And I'm not going to wait around for the accident. I have thought about a specific way in which I could hasten that outcome, in which I could actually bring that outcome about. And those specific thoughts are what we describe as plans, what we describe as, and those plans will involve means, whether it's ingesting medications or using firearms. And each of those means have risks associated with them as well, but none more important than access to the means. I was interviewing a patient today who was talking about the fact that they had a very specific plan, but it was based around, obtaining some things off of the dark web and all of these things, and was very specific that they did not have access to these means. But it also was very clear that they had been thinking in those specifics. And so all of those factors have to come into play in assessing what the active risk of the patient sitting in front of you in the office is. But I really think that in broad categorizations, passive suicidal thoughts are going to tell you about their suffering. The plan and intent and the access to that is really what's telling you about the danger. That's the thing that you have to address immediately in front of you.
Yeah, so let me reframe this in a way that I hear it not infrequently, that a parent will be quite alarmed and say, so my child has been very sad and has mentioned that they think the world may be better off without them here. What's my follow-up to that?
Well, I think in discussing that with the patient, it's first of all really important to understand a little bit why they feel that way, obviously.
Mhm.
But I think very important and realistic follow-up question is a very direct question of, have you thought about a specific way in which you might want to end your life? If you're having these thoughts about feeling that, the world would be better off without you, have you had specific thoughts about how you might bring that about? And it really being that upfront and focused is the best approach, because for patients that have been in this space and have been thinking that concretely, it's a pretty natural thing for them to say, yeah, I have thought about that. Versus the other side of the equation where patients have really just been suffering, and this is more just an expression or a manifestation of their suffering, you'll often be met with, no, I would never do that kind of a statement. And so I think it's through those direct asking of those very specific questions that we can tease out a little bit which side of the risk equation these patients land on.
One of the things I worry about is that if someone has a plan and they're very dedicated to this plan, are they just going to tell me what I want to hear? Are they going to not let me and medicine, all the forces for life and good, interfere with this plan? And so they'll just say what they think will get me off their back.
Yeah, we do hear that a lot, right? This idea that if a patient, really doesn't want you to know, they're not going to tell you. And there may be some truth in that. And to be very honest, when you look at the actual kind of situations surrounding individuals who complete suicide, most of these are folks that didn't have a mental health visit. They weren't talking to somebody.
Yeah.
Nobody was even aware that those thoughts were even there. And so I think from our standpoint, it's the asking that socializes this idea that first and foremost, it's normal to have these thoughts for a lot of these kids. And even in that kid that may be a little guarded, just the fact that you bring it up in a way that can be framed as protective, Just saying, like, I ask every teenager this. Like, this is something I ask every teenager. I'm not asking you this because of anything. I ask every kid this because this is something lots of kids talk about. And when it gets normalized, that might bring down that barrier for that particular patient that may feel guarded. So I really also feel like it's important in those situations to separate the disclosure from the consequence. Because again, a lot of kids will feel like, well, if I talk about this, it means I'm going to get locked up in the psych hospital. And I think the whole concept of safety planning with an open dialogue with patients where they're able to discuss these risk factors openly, oftentimes there's an outcome that doesn't lead to that. It's really more the more guarded kids that won't talk to you, that you just don't have another choice other than to go that route. And so I think it is in the asking that you can tease that away. And if they're not going to tell you, they're not going to tell you. But I think the majority of kids who are struggling or suffering out there are kind of just waiting for the right opportunity to talk about it. And I think we have a very, like I said, a privileged opportunity to be the people that are oftentimes trusted with those discussions.
To quite literally throw them a lifeline.
Yeah, exactly.
Yeah. I think you've suggested this already, but what's the concept of imminence?
Yeah, so I think when you start talking about the idea of risk and the idea of, I've got this kid sitting right here in front of me, I need to make a decision about what happens next. Imminence really speaks to the idea of a patient is at risk and really they don't have the capacity to maintain their safety, that without some active external intervention, the threat of harm to them is imminent. And so I really feel like that's the important thing to tease out. And I will often engage with patients in just a very honest dialogue. We know that the concept of a safety contract, asking the patient to promise us that they won't hurt themselves, that just doesn't work. There's no good data around the fact that being preventative. That said, I think patients can be pretty honest in their own capacity to gauge how confident they feel in their ability to stay safe. And I will often just have a very real conversation with patients about, if you were to go home from our visit tonight, what's the likelihood that you're going to be in this space of wanting to hurt yourself and not be able to talk to a friend or a family member, or not be able to engage in some of these safety planning skills we've talked about? And I have found that at the point the conversation has gotten to that point, patients will be pretty honest with you. And they'll just tell you, I don't know. And I don't know is an answer in and of itself. And so I think the idea of eminence is around this concept of judging, if I were to have this patient leave my direct observation right now, what's the likelihood that they are going to engage in these behaviors? And I think there are some structured ways to go about that through safety planning and other types of assessments that will help guide that assessment. This is not something you have to come up with kind of on the fly or on your own.
Does it help to identify a buddy, a lifeguard, somebody that if they started to have more intrusive feelings, that this is the person they would confide in?
Oh, 100%. And that's one of the core components of a safety plan. I think any patient, and this is one of the areas that we really have good, strong evidence for, is patients that we are, finding ourselves having these conversations with, and these topics are coming up with. It is important to engage in a very kind of specific plan around what will keep them safe. And a big part of that plan is identifying the individuals that they know of ahead of time. They've already thought this through. It's not a decision that they have to make in the moment. It's even written out on a piece of paper. These are the top people that I have already identified as my go-to people. And I have planned, together with my provider and my family and everybody, that I will reach out to them before things escalate further. And that can be a really protective factor for patients.
If you had to name the top things to put in a safety plan that you feel will be safe and effective, what would it include?
Yeah. And the way I really like to think of a safety plan is it really is an action plan. It's not a promise. It's not a contract. We know that type of language doesn't work, but it really is a plan that when somebody is in such a state of emotional distress that sometimes their critical decision-making capacity is diminished, that plan's laid out for them. All they need to do is follow it. And really that plan starts, I think, with helping patients identify the skills that they do know they have, some just basic coping skills and strategies. And those can be as simple as deep breathing exercises, to as complex as meditation or other types of skills that the patient has learned throughout treatment. And really understanding those skills and having them written down becomes this grounding thing that patients can start with. And so they start there. And chances are, if those skills are not working the way they want to, we move on to the next step. And that next step is really, who are the social supports? Who are the trusted people? And these are not necessarily the parents. These are the friends.
Mm-hmm.
These are the
Mm-hmm.
people that they really feel like they can be around and talk about and be themselves with and be honest. At the point that they've engaged that group of folks and there's still concerns, that is where the kind of adult accountability, getting parents involved, the people that know the kids and know kind of what their needs are. So who are the adult contacts in this patient's life that are going to be important? And then finally, the ultimate safety net here is, the professional backup. These are the professional resources we have. This is the 988 line. This is using the Safe UT app. This is calling a mobile crisis team, or this is just having your parents take you into the emergency department to have a talk with one of the crisis workers. And laying it out in that stepwise fashion kind of allows the patient to engage in a process that for many is very sufficient. Just to have a reminder of those coping skills and strategies, and that can be enough to kind of de-escalate things. But you have these very well predefined kind of phases that are escalating levels of support and care that the patient might need depending on the level of crisis they're in.
I think sometimes we're a little squeamish about the notion of talking about means restriction, but that seems like it's absolutely central to this.
100%. I mean, like I said, there are not a lot of really good predictors of, these really severe outcomes that we are avoiding as far as people who are completing suicide. But, some of these strongest predictors really have to do with access to means, firearms obviously being one of the biggest. But we also know that patients tend to, especially our younger patients, who may be in this state that otherwise would not have led to a behavior, but just the fact that there was access to something impulsively to grab, that can make the difference between a thought or a behavior. I can feel the frustration from a family standpoint of, feeling like you're walking on eggshells and having to lock everything down. But there really also is, I think, value in communicating to the adolescent that we're taking this seriously. This is very serious and this is very important. And yeah, we are going to keep you safe and not have things in your environment that you could potentially impulsively act on. That said, I mean, I think the highest and most important one to be evaluating here is access to firearms. I don't need to tell pediatricians this. I think they're very well aware of the importance of assessing the potential access to that and really counseling families on the importance of restricting access.
Well, the concept of second chance between many overdoses and firearms is just not comparable.
You nailed it right there. I mean, the lethality of the means is a very important thing to consider.
There was a terrific PSA here in Utah a few years ago that was made in cooperation with one of the gun rights groups. But the PSA was this guy going to his friend and saying, I'm really worried about you. You've been really down. Why don't you let me store your firearms while you get through this rough patch? And I think that being able to engage in that conversation is so absolutely vital.
Oh, 100%. And I think some of the most understanding patient families I've worked with have been, families with plenty of firearms in the house,
Yeah.
hunters, it's part of their culture. And yeah, I think there is this misconception that people who are firearm owners are somehow going to be averse to this idea of securing the firearms, where my experience has actually, been quite the opposite, that people that tend to utilize firearms for recreational purposes or whatever tend to also often know quite a bit about firearm safety and understand that importance, especially when it's brought up by a professional recommendation.
Any last words on this? Anything else you think we had to say? This has been very helpful. I feel like I can make a plan better than I may have.
Yeah, I think having a strategy for your practice, understanding that if you have a patient for which you have this concern, utilizing some type of standardized instrument, and there's a number of them out there, the ASQ, the Columbia Suicide Rating Scale. These are pretty straightforward, but they're just very direct questions that can assess some of these things we're talking about: passivity, intent, all these types of things, and having a care pathway kind of built around that. We can safety plan and help this patient get back home, understand they can be safe, versus this is a case where we really need to escalate this to maybe a crisis evaluation. And I think if you have a pathway kind of set up in your practice that you feel secure around, I think it takes away some of that stress and anxiety about having these conversations with your patients.
It really seems to me, too, that the screening tools not only help assess risk, but they open the conversation. that almost regardless of how people answer these, it means that the door is open and this is what we're talking about.
100%. And this is the whole concept behind the Zero Suicide program that is, such an important force for education in the country and across the world. But this idea that universal screening for suicide is a very important part of what we do. And it's right alongside universal screening for depression and talking about anxiety. This is part of our care. It's assessing mental health. And I think at the point that you destigmatize things in that fashion, this is just something we ask everybody, it becomes an easier conversation to have.
That's huge. Dr. Kendrick, thanks so much for your expertise and thanks for talking me through this. Those of you who have questions, please send your questions to questions@vcurb.com. I'm sure there will be questions and we'll look forward to talking about this in a couple of weeks. Thanks, Jeremy.
Thank you. Appreciate it.
All right. Talk to you next week. Thanks for joining us. We look forward to getting together again next time. The Virtual Curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Paul Wirkus, who composed the theme music. See you next time.